Good afternoon, everyone. Welcome to Endocrine Grand Rounds. It is my pleasure to introduce Dr. Aurelia Wood. Dr. Wood is a product of Wright State School of Medicine. She then was here with us in Louisville at Norton Children's and the University of Louisville for her pediatric residency program training. And then she did endocrinology training at WashU in St. Louis before she started her academic career at Ohio State. Before finally coming home, we were able to recruit her back, and she has recently joined our faculty as a new faculty attending in pediatric endocrinology. And so today, we're going to hear work that she has really dedicated not only her early career stages to, but also her training to, and that's focused around diabetes and health equity. So please welcome Dr. Wood.
Good afternoon. Can you guys hear me? Thank you for all being here, even though my voice decided it wasn't going to be. Just losing a little bit of that voice. So my topic, as you can see, is titled, What About Me? So I'll be talking about evaluation of inequities in pediatric type 1 diabetes, tech utilization, and strategies to improve access and outcomes. I have no disclosures to review. So we know a lot about the background of the health equity and inequities. So I'm going to just briefly start by recalling the history and current landscape of management of pediatric diabetes, spend some time talking about the root causes of those inequities in utilization and how they impact outcomes. And then as we go along, I'm going to introduce some strategies from literature and institutional experiences that help us to address those inequities and improve outcomes and use. So it took the better part of a decade for large-scale production of insulin to take place after the first dose of insulin was successfully given by the team working with Dr. Beston Banting. But it wasn't long after that that the recognition that technology could actually play a role in diabetes care was recognized. We see here one of the first, if not the first, prototype of an insulin pump by Dr. Arnold Kadesh in 1936 while he was practicing in Los Angeles. This huge backpack was actually a closed-loop system that cycled blood draws, delivered insulin with an off and on switch, and also included glucagon. So really forward-thinking and progressive, especially considering the available technologies at that time. Predicated on Dr. Kadesh's work, a lot of other researchers, both nationally and internationally, began to explore other ways to deliver insulin outside of injections, including some other earlier insulin pump prototypes. And in the 1980s, we got our first clinically approved insulin pump here in the United States, which was the Medtronic MiniMed. Over the next decades, we saw improvement in home blood sugar monitoring devices, the advent of blood ketone monitors, and then some of the first CGMs. And then in the 2010 to 2020 timeframe, we got our first tubeless pumps. We got some additional types of insulins, and we also, in pediatrics, were approved for use of Dexcom and other CGMs in our practice. And over the last 10 and especially the last 5 years, we've seen just exponential growth in the available technologies that really are sophisticated and help our patients to take care of their diabetes. And we're familiar with a lot of that research, so I'm just going to briefly touch over that. But in 2016 and 2017, there were a number of large-scale, multi-site randomized controlled trials looking at the safety and efficacy of CGM, including the InControl, Diamond, Gold, Impact, and HypoDE studies. And as you can see here, these studies showed that CGMs were effective in decreasing hypoglycemia, improving A1C, and also improving quality of life. Similarly, for insulin pumps, we have lots of different studies that show similar outcomes in terms of improving glycemic control, including improving rates of hypoglycemia and severity of glycemia, as well as improvements of quality of life. And now that we have our automated insulin delivery systems, our hybrid closed loop systems, we also have a number of industry-sponsored and academic rooted studies that show that these devices are safe, have positive user experiences and feedback, are effective in improving time and range, reducing hypoglycemia, as well as improving A1C. So of course, our goal is to get these things to our patients, right? So that starts with our patients having an endocrinologist coming into clinic, having a good, productive conversation, having that nice, good therapeutic relationship to discuss whether technology is appropriate for them so they can get that prescription. The next hurdle is insurance. So then we get that improved and we get the patient their pump device or their CGM in hand from a durable medical equipment company or their pharmacy. And then we initiate that initial education and support to help them over time have that long-term success that we've seen in those other studies. So how do we choose who we should give a pump to? So the 2020 Standards of Medical Care in Diabetes, published by the ADA, said that the consideration of use of a pump should be based on the patient's needs, their skill level, and what available devices are there. And then initiation of a pump should be considered based on patient and family readiness, what types of pumps they think would work best for them, what their initial settings may be, and that's imperative that you should provide education on complications in managing those, hypoglycemia, ketones, the process of transition from a pump to a CGM or a pump, subcutaneous to a pump and back if needed, and then also providing that education on the advanced features of a pump. However, there's really no specifics in terms of determining that patient and family readiness, because that really is the rate limiting step, because ultimately most of us aim to get our patients on these technologies. So that comes down to our clinical judgment, right? And we probably all have some shared clinical judgment and criteria that we use when we're thinking about a patient and what their success with the device might be. So mostly that's their baseline diabetes skills. Can they carb count? Can they treat lows? Do they know how to give their insulin injections? Can they problem solve? When you have that low, are they able to do the rule of 15s appropriately? If they run out of prescriptions, are they able to call? For our pediatric patients especially, it's really important that they have either a caregiver or some other direct support system. And a lot of times we consider if they're doing well with CGM, knowing that the hybrid closed loop systems require that device. And then there are other specific individualized considerations. Maybe they struggle with shots, but otherwise do great. So a pump would be perfect for them. Maybe they have really variable eating habits. Maybe they're super sensitive to insulin, like our kids in the honeymoon phase or our toddlers. Maybe they just need a really flexible dosing plan, or maybe they're very active. And there are many, many other factors that you all probably are considering. However, even though these are great and objective and allow us to make sure we're taking care of our patients well, there is the potential that there are some potentially negative factors that we consider as well. Some might have an idea of the model patient who they only prescribe pumps to. Some may face limiting institutional practices regarding diabetes technology that don't allow them to give them to everyone. Some people might have a family that they don't feel trust in giving a device to, whether it's founded or unfounded, and worry about liability if they use it improperly. Insurance, of course, is a huge consideration because that's a big barrier to getting it approved, but really knowing what those insurance guidelines are is important so that you're not accidentally biasing someone. And then consideration of where a patient lives in regards to the Mind Diabetes Clinic. So here in Kentucky, we're here in Louisville, we have a huge catchment area. We have patients that come from 10 minutes away and 5 hours away. And then there are those unconscious things, those things that are unsaid, those implicit biases that may impact prescribing habits, things such as implicit bias by race, culture, or ethnicity. So although we would like to and should presume positive intent in our own and our peers' prescribing habits, we know from the growing body of literature about disparities in diabetes technology use that these things do occur and do impact outcomes in diabetes technology use. So one of the largest studies in pediatrics was published by the Type 1 Diabetes Exchange QI Collaborative. So this is a multi-center data sharing QI initiative that began in 2016 that allows for large-scale collaboration in terms of addressing multiple different things, a huge priority right now being discrepancies and disparities in diabetes tech. So they looked at patients between 2016 and 2022 across 15 different academic centers, 12 of which were pediatric, 3 of which were adult, who were at least 1 year of age, had had diabetes for at least a year, and had at least one A1C the prior year. And overall, they were able to review almost 10,000 charts. And so this first graph shows the trends they noted by race in terms of CGM utilization. So you can see that at the beginning of the study period in 2016, to the end of the study period in 2022, that the rate across the board for all patients did increase in terms of utilization. However, when we divide that out by race, though there was a pretty similar rise in the percentage over time, in the end, there was a disparity between Hispanic Black, Hispanic, and non-Hispanic white patients, with 83% of white patients using CGM and only 57% of Black patients using CGM. The change in pump use over time was a little more modest, but it did increase overall. But again, there was at the end of that study period a huge discrepancy between non-white patients and white patients. And finally, once AID or hybrid closed loop systems became available in 2018, there was exponential uptake across all groups. However, the most significant increase and the largest number, again, was in those white patients. In this study, they not only looked at utilization and uptake, but also outcomes in terms of A1C, adjusted for a number of confounders. So looking across our 3 different groups, over the course of the study period, the A1C improved by a mean of 1% in the non-Hispanic white patients, compared to an increase by 0.4 and 0.9% in the other 2 groups when adjusted for age, gender, and duration of diabetes. Adding in technology use, that increase was still significant, though not as pronounced, but there still was a predilection for people who were non-white to have higher A1Cs. So we know we have this beautiful trajectory of development of type 1 diabetes technology. We know that it improves quality of life and glycemic outcomes. So why are certain groups getting benefit and certain groups not getting that benefit? So what's missing? Like, what's that puzzle piece that's missing? It's considering that, as researchers and scientists and physicians, we read papers from all over the world, but we practice in Kentucky, we practice in the United States. So we have to think of our patient population, which is made up of a beautifully diverse group of people who may be immigrants or from families of immigrants, who may be Indigenous Americans, who may be differently abled, who may be from the LGBTQ community, who may be Hispanic, Black, or from another identity, and from a group that has been historically vulnerable to complications and more vulnerable to poor health outcomes. So to better understand that, we have to understand the context of the United States. So for those Indigenous families, we have to consider that they come from a background of being colonized and having their land and having their quality of life, their civil rights, their civil liberties taken away from them, and how that structural change has impacted not only their everyday life, but their health outcomes. For people who identify as Black and African American, we have to consider that they come from a background of products of the transatlantic slave trade and have had to work over time to gain civil liberties and civil rights, and what that has translated to in terms of social interaction, engagement, education, and health. We have to consider the experience of those who have immigrated to the United States from different countries in Europe, Asia, and Africa, the Caribbean, and others, who have been faced with resistance of varying degrees of welcome and exclusion in this country. We need to recall the experience of those within the LGBTQ plus community who have had to fight for equality and recognition without harm. And finally, we must also consider those with physical disabilities for whom legislation to protect them against discrimination and harm has had to be implemented, which has only really been recent the last couple decades. And many of us don't just fit in one of those groups. Many of us identify with multiple different identities, and that's intersectionality. So the network of connections between social categories, such as race, gender, and ethnicity, especially when they may result in additional disadvantage or discrimination. And there are many other types of characteristics and identifiers, as noted here in this graphic, that may also be unjustly used as grounds to create or maintain a power differential, which is then used to oppose another group. So the impact of this systemic oppression spans beyond health and goes into other aspects of human existence: wealth, employment, educational opportunities, housing opportunities, which may result in different disparities and negative experiences, such as lower rates of home ownership, poor access to health care, higher morbidity and mortality, and gaps in educational achievement. And all of these categories really fit within the social determinants of health, which is those 5 domains of the environment that directly impact our health and wellness, and thereby can mitigate and really impact our overall health outcomes. Because of these influences and experiences, children in particular facing negative impacts of social determinants of health are more prone to toxic stress and adverse childhood events known as ACEs. So when we think again about that pathway to success with diabetes, we have to think of our own personal experience within that context, as well as our patients. So let's start with thinking about what kind of barriers or impacts may face clinicians and prescribers in thinking about diabetes tech. So starting with implicit bias. So in 2021, the Type 1 Diabetes Exchange did a really interesting multi-center study to try to evaluate the impact of implicit bias directly on prescribing Type 1 diabetes. And so they were able to include 109 different adult and pediatric clinicians taking care of patients with diabetes, 75 pediatric, 34 adult, and provided them with the modified diabetes provider implicit bias tool. So this is kind of a two-part tool. The first, you're given a clinical vignette, and then you have to decide along the course of that vignette whether or not you'll prescribe technology to that patient. And then the second part is a ranking tool. So ranking 7 different aspects of patient-facing considerations as to whether or not you would consider those in prescribing technology. This table on the right shows the participant demographics, most of which were female, most of which were white physicians, most of which practiced in an urban academic setting. And so this is a table showing the results of that ranking exercise, with 1 being the most important and 7 being the least. And so of the respondents, most said that technology preference by the patient was the #1 thing that they considered, followed by whether or not they're monitoring blood sugar, their A1C, insurance, age, and then ranked income and race and ethnicity very low in terms of factors they consider. 55% of respondents noted that they had completed implicit bias training. However, the results of the DPIB showed that 34% did indeed show race and ethnicity bias, and 61% did show insurance bias, with a higher odds ratio of having racial bias when they answered the question, I am able to recognize my own bias as agree. Similarly, researchers in another setting looked at publicly insured patients who were young adults between 18 and 28 and outcomes of their technology use, and whether adjusted or unadjusted for socioeconomic status, their healthcare factors, their diabetes management, use of pump and CGM were lowest in Black and Hispanic patients. So we know that those implicit biases do translate to lower prescribing rates. So what can we do about it? So the first is implicit bias training. I think that, many of us have been through this, especially in the wake of the social justice awakening of 2020. Institutions, especially healthcare institutions, really began to pay attention and strengthen and intensify efforts in this area. However, from that study, we know that implicit bias training does not always translate, as a proportion of people still will have different prescribing habits without recognition. So that asks us to create innovative protocols and programming to make sure that we address that. And a great way to do that is through QI, that's designed to create protocols and practices that not only address that root cause, but also promote accountability. Other ways that we can make sure we're providing equitable access is to make sure that all clinical locations provide the same level of care and education about technology, that all materials related to technology are interpreted into multiple languages, and that we have a variety of learning tools, because every patient doesn't have the same degree of basic literacy, let alone healthcare literacy, or importantly in this day of technology, electronic healthcare literacy. In terms of insurance, the first thing is to really just operate objectivity, really knowing that this patient is or is not eligible based on their insurance, rather than presuming or allowing them to presume that they are not. So this could be addressed with simple interventions such as posters, handouts, dot phrases, and EPIC that help us to recall and stay on top of these things, because they do change annually. There's also a huge role for state level advocacy of expansion of Medicaid criteria. At Nationwide Children's, our QI team was able to work with Medicaid and provide them data on CGM utilization and improvement of glycemic control. And they actually reduced some of the criteria for prescribing for Medicaid patients. So it is effective. Also want to advocate within our own institutions for patient assistance programs so that financial and insurance are not a barrier, and then partner with device companies for patient assistance programs, providing samples and other ways to help them get to those devices and use them more successfully. Another area that can be a potential bias is geography. So again, how close you live to those diabetes centers. And on the right, you see a map of Kentucky with all the adult centers. Not all of them have endocrinology, and then our 2 pediatric centers. So interestingly, the incidence of type 1 diabetes is actually 2.28 higher in those who live in rural areas compared to those who live in high density areas. So we know that these patients are actually more concentrated in those areas. And rural youth and adults actually have higher mean A1Cs compared to their age matched peers that live in urban areas, and CGM and pump utilization are lower. In addition, we might find that CGMs are prescribed but not fully utilized to their full capacity. This study utilized CGM billing at appointments as a surrogate for CGM utilization and found that patients who lived in urban and larger rural towns had more often came to clinic prepared with their CGM, with it connected, and able to use that objective data to make decisions about their care as compared to people who were in smaller rural towns or isolated rural towns. We now live in a post-COVID area, but pre-COVID, use of technology and studying that in the space of telemedicine, there really wasn't a lot of literature, and a lot of people weren't doing virtual pump starts and CGM starts. But there are a couple studies, one of which is this really interesting study that was done by Barbara Davis at University of Colorado. So this graphic on the right shows their huge catchment area, which includes Wyoming, Colorado, Nebraska, and most of Kansas, west of Kansas City. And so they have actually been doing this clinic to clinic telemedicine model for about a decade before COVID even started. And so they wanted to evaluate if there were discrepancies and inequities in tech use at their baseline. So they studied 128 patients who were seen in this clinic to clinic virtual setting and compared them to their main campus setting. So in that study group, they had 128 patients compared to the almost 4,000 patients at their main campus. They were pretty well matched in terms of male versus female, their A1C, their median length of diagnosis. The patients that were in the study group were slightly younger, 12 at mean versus about 14. But of course, the major difference was the distance that they travel, with those in the study group traveling 386 plus or minus 170 miles to get to that appointment. And so the way that these visits worked is that the clinician was at the main campus, connected virtually. The patient and their family would go to a local site where an MA nurse or CDE would do vitals, upload all their devices, ask them questions, go through their history, help assist with physical exam, and then the clinician would join. So a really, really robust model, which is almost the exact same as an in-person visit, unless the doctor isn't in front of you and unable to do the exam themselves. And so they found that even with this really robust model, that patients seen at the main campus still had a higher overall rate of CGM utilization, that patients who only use CGM as their technology was also higher at main campus, and that patients that use pump only actually was higher at those who weren't seen in the main campus setting. So some of their observations was that A1C was lower in technology use with both groups, so overall still positive, that CGM use seemed to independently correlate with the reductions in A1C, and that pump use only seemed to increase as age increases. But they also noted that there really was nothing that they could identify that really explained these discrepancies. And many studies about rural patients seen in rural settings share the same thing. In a lot of racial studies, ethnicity studies, there's a lot of ability to identify root cause. However, it seems to be a trend in studies looking at rural patients that it's a challenge to identify exactly what is the barrier to them successfully using technology. So since COVID-19, with everyone needing to essentially use telemedicine, that's actually provided an opportunity to streamline and refine telemedicine care. And many centers have implemented robust QI and programmatic efforts to improve the virtual clinic workflow, both before and during the appointment, to operationalize connectivity to platforms so that you have that data to review, and to safely and effectively start insulin pumps. So we know that we can do these things and that we can do them well to help patients that are living in remote areas take care of their diabetes. But again, there's still that missing piece about exactly what the main barrier is. So this may ask us to look at the socio-ecological model, which is a framework to contextualize how health outcomes are influenced by individual factors and interactions within families and communities. We may gain some insight into what these factors are by learning from those who take care of patients in rural settings. So this chart is from the Rural Health Information Hub and asks those who are rural stakeholders, so those across education, government agencies, healthcare, and other settings, to rank what they feel are the most important factors for their patients in the rural settings. And the number one and number two was mental health and addiction. Interestingly, healthcare access and quality had been number one for the past 20 years, but has now moved down, but obviously is still a consideration because being that distance from the clinic is still a challenge. And over time, universities and institutions are steadily placing healthcare locations at the further points of their catchment area, but this takes years and years of development, institutional priorities, and frankly, millions and millions of dollars. So in the meantime, there are some unique and novel interventions that can be done to help supplement that care. One that I wanted to share was from St. Louis Children's Hospital, who last year implemented the first mobile unit for pediatric type 1 diabetes care. So they are going to the northern portion of St. Louis County, known as North County, which is a predominantly Black and Hispanic area that has historically faced many inequities and disparities across domains, but especially in terms of diabetes, obesity, and heart disease. So in this mobile unit, they provide appointments, they complete lab screening, they do retinopathy screening. They also go to the sites at the schools and teach the nurses, teachers, and staff how to check blood sugar and how to deliver insulin. And they also provide nutrition services for patients with prediabetes. All of this is free of charge due to charitable giving to support the effort. So this could easily be replicated in a rural setting if you identify regions that have high volumes of the main site's patients, hire and train staff under the institution, and then centralize that mobile unit to them so that they get that exact same care in person, one-on-one, as they would in the main campus. Another great way, especially in pediatrics, to address gaps in health is school-based health centers. So there's actually 99 different school-based health centers here in Kentucky. So that is definitely an area of opportunity to partner and, again, bridge the gaps, give that one-on-one direct evidence-based good patient care. School-based health takes many different forms. It can be in the clinical setting, it can be telehealth only, it can be linked to where it's a hybrid of in-person and remote, and there are also mobile health services. In terms of school-based efforts for type 1 diabetes, there's really a paucity of literature and efforts, and most focus on education, rightfully, for school staff and nurses who take care of the patients with diabetes. I wanted to share something that I was able to be a part of and initiate at Nationwide Children's called Diabetes in School Health Program, which was a school-based health equity intervention to help address, mitigate, and reduce disparities in technology use and overall diabetes outcomes in the most vulnerable patients. And so the goal of the program was to increase self-efficacy and independence, improve comfort, knowledge, and consistency in type 1 care at school, and facilitate improved communication in order to optimize diabetes care and really get some of these kids who have very low rates of tech uptake improved. Now in its third year, we have found that we were able to improve A1C from average 12.4 to 10.6, that at baseline, 16% of kids were using CGM regularly. That's now up to 81%. And that initially 7% of kids were using pumps, and now 28% are. So school-based interventions are well received, work very well, and can be very effective. And similarly to that mobile care unit, could easily be replicated in those rural areas under direct training from the main institution. So now that we've thought about some of the barriers and factors that apply to prescribers, we have to think about the patient's experiences and what they may have in terms of hesitations, barriers, or concerns. So some researchers at Yale did a really interesting innovation where they did some interviews with families and adolescents affected with type 1 diabetes who self-identified as Black to figure out if there were any specific barriers that they faced in terms of their overall diabetes care, but really in relation to uptake of diabetes technology. The adolescents shared that the intersectionality of multiple identities, being Black, being a teenager, having a chronic disease such as type 1 diabetes, all impacted their ability to kind of function within their social groups, but really to want to even go further and implement type 1 diabetes technology into their care. They cited lacking having peers that look like them and increased visibility potentially with having devices as being barriers, and noted that they wanted more independence, but just weren't sure they'd be able to handle a complex decision making that sometimes technology asks for. The parents cited lack of community, lack of support in and out of the home, a lack of recognition of cultural differences with family dynamics, diet, and cultural practices, as well as worry about safety and acute complications as reasons that they were hesitant for their children to use type 1 diabetes technology. And some overall themes that emerged were fear, mistrust, family and culture, financial barriers, unwanted visibility, and need for more exposure and education to those devices. So it does not surprise anyone that diabetes distress is actually higher in Black youth as well as in Hispanic youth. At the same time as this study, researchers in Boston were actually doing something very similar to explore challenges faced by Hispanic youth. And so they did 12 one-on-one semi-structured interviews as well as focus groups for parents of kids with type 1 diabetes, the demographics you'll see on the left slide. And these 4 domains of barriers emerged. The first being culturally based nutrition challenges, noting that food and celebrations with food were such a big part of their culture that it became very challenging to constantly explain and try to redirect. With one mom noting, what happens is that we have to educate ourselves all the time because the food in the United States is just very different from ours. It's a part of our culture and changing it is very different. They also noted social isolation and lack of support for diabetes care as a concern. One mom saying, for me, the hardest thing has been making my family understand her diagnosis because there's no one in our family with type 1 diabetes. Also, culturally, it's very different with people always saying, why can't you give her food? We're all happy eating. In general, there was an overwhelming positive experience that the patients experienced with their caregivers. So noted very good positive feedback and engagement with their team. So really no barriers in terms of working with the team and communicating, even for those who preferred to speak in Spanish and use an interpreter. However, they did cite some hesitancy to use on-call services at time that they did need help because of fear of being misunderstood. And finally, they showed some of the parents expressed a hesitancy to embrace technology because though they understand that it could be a positive addition to their health, they were worried about the physical burden and their child looking different and having to wear something on their body to treat their disease. So overall, thinking about these 2 groups, some of the themes that emerge are the importance that we recognize their intersectionality, that we help them build and maintain community, that we empower the patients, their parents with peer groups, and that we provide them tailored information. And indeed, in both groups, some of the things that the families and the patients shared is that they'd be interested in group-based medical care, that they would be really interested in doing shared medical appointments across specialties, that they would be very helped by culturally tailored nutrition classes to help them with carb counting, and that they would love to have support group with other families. So these are things that we should consider implementing, especially because we do take care of a number of patients from various backgrounds. Insurance, we don't need to spend a lot of time on because we know those barriers. Unfortunately, these vulnerable populations often have public insurance, which we know have often very stringent criteria for which they will improve technology, specifically CGM. And often those criteria are the exact barriers that we're attempting to overcome. So saying I need 4 blood sugar checks a day, the reason I want for the CGM is because they won't check their blood sugars 4 times a day. So it's varied over time. And in some states, Medicaid is actually becoming more welcoming. Here in Kentucky at present, the criteria is to be taking at least 1 insulin injection a day. But for patients with type 2 that aren't on insulin or taking other medications, kids who are in the honeymoon that might not be on insulin, or kids with hypoglycemia or other concerns, we are unable to get those approved. And overall, we know that high cost of type 1 diabetes care for those with poor coverage overall will lead to poor outcomes. So what can we do as clinicians, as institutions, as universities? Really, these are state and federal level issues. And so we really have to advocate and be aware of all the different avenues that we potentially have to advocate on behalf of our patients. Whether it be meeting with our representatives to discuss the dozens of bipartisan bills that are available to make insulin affordability a reality, partnering with insulin advocacy and type 1 advocacy organizations to be a part of the solution and really engage with the community, as well as in our one-on-one interactions with patients, not letting them get discouraged and continuing to offer them CGMs, letting them know that it's available for them because sometimes they presume that it's nothing that they can do because of their socioeconomic status. Another really effective method of large-scale intervention for patients with Medicaid are accountable care organizations. So these are groups of doctors, hospitals, and healthcare workers that coordinate together to specifically ensure high quality care for patients with Medicaid. So Partners for Kids is the oldest and largest accountable care organization for pediatrics, and its home is at Nationwide Children's. And so they have care navigation where they partner with a patient and help them get to their appointments. They have care coordination for patients with complex histories in order to reach out to the clinics, their prescribers, to help them coordinate their care. And they do a lot of different interventions and help patients and families navigate things, especially those that have different varying levels of literacy and barriers due to social determinants of health. These organizations are extremely effective in preventing morbidity and mortality, and have shown to reduce hospital stays and frequency of admissions, as well as acute care utilization. And finally, we know that patients need ongoing follow-up and engagement with their diabetes team in order to receive this benefit and make sure that they're getting the full scope of outcomes from their diabetes care. A lot of times we presume that follow-up rightfully plays a huge role in that. We want to see our patients every 3 months so we can examine them, so we can talk to their families, we can find out what their needs are, but also we want them to, at those appointments, meet with our other ancillary staff, their dietitian, the social worker, and the educator, who are supremely important in addressing all the scope of what managing diabetes at home means. So one group decided to study and investigate whether follow-up and follow-up with the ancillary staff have any impact on outcomes. And what they found is that though patients who had higher hospitalizations and acute care utilization were having less clinic follow-up, they were the ones who actually followed up the most and the most closely with the ancillary staff. So those are kind of contradictory to kind of what we usually think in terms of you're not getting your education, you're not following up with what we need. So that lends a question as to what's going on within that clinic appointment that could be optimized so that we get that full benefit and mitigate the need for acute care and hospitalization. So really poor outcomes are not necessarily due to a lack of follow-up. So some of the conclusions that they found through discussions with families and other stakeholders is that rescheduling patients and getting that back in is effective, that there is lesser engagement with staff and clinicians for various different reasons, and that some families and patients cite poor diversity and representation in the workforce and a feeling that there's less emotional connection as reasons that they sometimes feel disengaged from clinic. So what can we do about that? Well, there are multiple different avenues that we can try to implement in order to make our families feel more connected, more engaged, and that we care about them in that way. So community health workers have been shown across multiple different specialties and chronic diseases to be cost effective and improving diabetes outcomes, especially in vulnerable populations, having that one-on-one connection, such as with the PFK. Efforts to diversify clinical workforce and mirror national demographics, may also improve patient and clinical relationships, like the patient cited, having someone that looks like me helps them to feel more seen. And interaction outside of the clinical setting may also engender feelings of connection. So having events for families, going to JDRF walks, going to hosting and going to events that are tailored to families, as some of the things that they shared with nutrition and other avenues, may really be opportunities for us to build that trust while working on other aspects of care. And finally, we need to always remember that we have to address the underlying etiologies of disparities as a group, and we have to make sure that we're always aware of the potential impact of implicit bias and the outcomes due to systemic racism. So overall, this is a really complex problem and requires really complex solutions, going from public policy all the way down to our one-on-one interactions in clinic. So in summary, use of CGM, insulin pumps, and hybrid closed-loop systems have been shown to be safe and effective. Uncovering and addressing the multi-level barriers to equitable utilization requires recognition of systemic and individual factors. It is our shared responsibility to implement strategies to address inequities, and advocacy, QI, accountable care organizations, institutional and school-based interventions are potential solutions to these issues. So thank you for your time and attention, and any questions are welcome.